So the investment case and a key gap for in preventing the elimination of viral hepatitis. And I mean, to your question, I think this is part of the problem, is that people have not realised the cost, and so therefore what needs to be spent, but what will be saved. And so that's why we're not getting the investment. I'd like to acknowledge a number of people and also note my disclosures. I receive investigator-initiated funding from Gilead Science, AbbVie and BMS. So John's already spoken to this. Hepatitis B is responsible for a significant number of deaths, as is hepatitis C. So both cause major global impact, big killers across the world. And that the numbers are going up as opposed to the other key diseases. The World Health Organization has set the elimination targets, and some countries are working towards it, but the reality is we have some problems. There is a fantastic vaccine for hepatitis B. Most people are aware of it when surveys are being done recently, but a significant proportion of people are not, and particularly that birth dose is not getting out to people as it should. And with hepatitis C, we have a cure. So there is no reason why we cannot eliminate this disease as a public health threat. But again, the community awareness of hepatitis C cure is certainly not there. But there's the opportunity for us to do this. And as I say, DAAs, I think, for hepatitis C have been a game changer. And Mike, in thinking about your question, I do think that there's a real lack of recognition, in the same way as we manage for hepatitis, for HIV, that hepatitis B, we can actually keep people well, and the impact of low-cost treatments, they're all off patent. There should be no reason for why we shouldn't be having globally better programs for the management of hepatitis B. This is extremely affordable. And the fact that it only happens, or people often only can access hepatitis B therapy in a country if they're HIV co-infected, I think is a tragedy and something that needs to be addressed. And so I think we need to work really hard for that. So how are we tracking towards elimination? Only 12 countries are on track for hepatitis C elimination, a few more for B because of that vaccination. But with the birth dose vaccine, hopefully with Gavi's real support of birth dose vaccine, I think we can go a lot further with hepatitis B. And importantly, work has shown that hepatitis B vaccine can come out of the cold chain. And so with that and some modelling that we've done and others, I think there's a real opportunity to think about really innovative programs to get that hepatitis B into to babies at birth in villages where you don't have great health systems. So I think that should be one of our big challenges for the next 12 months. And I would be calling on people to get onto various groups, thinking about the various, Rotary, whoever, to say maybe now that polio is under control, why not have Rotary have this as their next big challenge or something like that. So if you're a Rotarian or know a Rotarian, maybe get them interested, because around the globe I think we could get them linked in. So why haven't we been successful? Well, partly because there's been a barrier to do with the price of treatment, or a perceived barrier. And I know I've got some colleagues here from one of the companies where they've heard me say this before. I actually think that the fact that it came in at such a high price, the DAAs initially, meant the conversation started in the wrong place. And that rather than us thinking that we could eliminate, we all talked about the price of these drugs, as opposed to the fact that the price of these drugs very quickly came down, that there was all sorts of things around how we can get these drugs cheaper through centralised price negotiation, licensing, compulsory licensing, generic licensing, all sorts of things, and that the conversation around hepatitis C elimination started, in my view, in the wrong place, but it's getting to be towards the right place. And with hepatitis B now, the roll-off patents, there is no excuse, again, for hepatitis B being too expensive, the treatments. It's now to do with health systems and government will. There are unnecessary barriers, and these have been put up for all sorts of different reasons, and I think this very much comes to stigma and discrimination. Stigma and discrimination for hepatitis C, because many people associate it with injecting drug use, but also within community stigma around transmission. We also see this with hepatitis B as well. And so until we really work on the issue of stigma and discrimination around these diseases, I think it's a real issue. And we haven't, because of it, often had the same community involvement or engagement as happened with HIV, in particular amongst gay and bisexual men, that really pushed along the HIV approach and global funding. I think stigma and discrimination has been a big barrier. But as well, one of the key things we haven't had for viral hepatitis, as has happened with HIV, is an investment case and a framework for why we could actually achieve elimination. So as part of the World Innovation Summit for Health, the Qatar Foundation funded this, and there was their summit in 2018. One of the topics that they chose was viral hepatitis, and I had the opportunity to chair that viral hepatitis forum, and we were asked to say, we basically did some surveying and some discussions around the world of what would be the kind of thing that would be really helpful for viral hepatitis, something we hadn't done before. And it was identified by people on the forum that the global investment case was really important. We needed a framework in which we can talk about it. So there's what's the financing sources, what's the activities need to get done, and what's the return on investment that one would get from this. And so we worked on this framework, and that WISH report is now available online, but I'm also happy to provide it to people if they would like it. It's a pretty simple document. It's done deliberately simply aimed at policymakers and investors as to why this is a good idea. So when thinking about some of the key features, we looked at what were the activities that needed to be done. We talked about what's the national activities and the international activities that need to be done for this to happen, and what are the key enablers for those. Because one of the things is we don't think that there will be a global fund coming in, riding on the white charger, bringing large dollars. It would be nice, and we would still be trying to encourage them or the Gates Foundation, but we have to understand that this response needs to come from within countries. And when one looks at countries like Georgia, Iceland, Australia, as to why, and Egypt, as to why they've moved forward, it's when their leadership has said we're going to be involved in this and there's engagement. So we need to work out how to make it that countries embrace this as an idea. We need international support from these global funds and global investors, but it needs to also come from country leadership, and how do we get them to engage? We also need to understand that there is benefit by doing this. There's a direct economic benefit, so we decided when we looked at the return on investment, and this is one of the big reasons when Egypt was looking at how much do we need to spend, but how much will we actually eventually get back? What's the return on investment for a program of elimination, be it for B or C, depending on what the epidemic is in your country? And there's a direct economic benefit, there's an indirect economic benefit, and there's also cross-sectorial economic benefits. And when one thinks about the Sustainable Development Goals and universal health coverage, and John alluded to this, this should not be done in silos, but if this is embedded within those responses, then we can go a long way to eliminating these diseases at low cost, but also leaving behind systems where we are better for other diseases as well. So many countries are implementing effective viral hepatitis strategies, but not enough. Egypt essentially is maximising return on investment through this rapid scale up, and I'm sure Manal will be talking about this soon, but it's just the most extraordinary program. And China, which is I'll also provide as an example, is really making progress against hepatitis B through a national commitment and public-private partnerships and a public health approach. They've done a series of things over the years to make it that they're making enormous advances with hepatitis B in China. So even in countries where these diseases are massive and the numbers are massive, they're making enormous progress because of commitment. So as I said, in China, they started off with a national immunisation program. They had a partnership with Gavi. Then with building through that partnership, they then began to make their own vaccine became available, the provision of vaccine and fees were taken away, and then increasing screening. But even more recently, China has then begun to make a commitment to actually treating people with hepatitis B. So it's a steady progress. Not every country will achieve it, will do things in the first year, but it's certainly a nice example of how essentially the efforts that China's putting into hepatitis B are making an enormous difference to this country to stopping new infections and to reduce the deaths related to hepatitis B. If we look at Egypt, and the top bit's fallen off, but Egypt is making enormous progress as well. It started a long time ago with a national strategy or control program, national plans, and then building through. And more recently, when I updated this, I was in an email tic-tac with Manal when I was doing these slides a couple of weeks ago for the Doha summit. You know, it was changing every day where I had to redo the slide because another 500,000 people have been tested for hepatitis C. It was the most extraordinary thing. And I think, what did you say? We're up to 14 million or something? 14.5 million people have been tested in the last 67 days. That is called commitment, and it's a national commitment, and it just shows what can be done. So I think that really, Egypt's are really showing us a real example of when you get national government commitment, what can be done. Similarly, just been the Georgian tag, and again, through national commitment and a national strategy and program, they're making enormous progress towards their elimination program. So why do we do this? Because if you actually look at where we will save money, you can do nothing and the status quo and your disease will continue to go up. You can have a bit of a progress strategy and you'll begin to get some disease coming down, or you can go for elimination and get disease to come down much, much faster. Why would we go for the elimination strategy? Because it will save us money. We'll get the global incidence down, because if you go to the other strategies, you won't. So the problem will continue on and on forever. Your mortality will come down a bit with the progress strategy, much more with the elimination strategy, but continue to go up and up and up, as John has suggested or said has been indicated, if we do nothing around mortality. And the thing is, although it will cost us money initially, and there'll be that, I don't have a pointer, but that initial hump of increased cost, as you can see by some modelling we did for the World Innovation Summit on Health, that essentially with the elimination strategy, that cost, basically you begin to save money by 2030, that the cost of eliminating becomes cheaper than the cost of the status quo very quickly. So you've got this initial cost that you have to spend globally, but then we begin to save significant dollars. And this is if you look at the direct health costs. By 2030, we begin to make changes. But importantly, when we began to calculate in the indirect health costs, you begin to save an enormous amount of money. And by 2027, when you take into account the indirect health costs that will come from eliminating hepatitis C, as you'll see that if you do status quo, you don't get anywhere. Even with progress, you begin to actually essentially upfront make money, but essentially the savings or the broader health economic benefits of elimination really come to the fore. And so this is the first time that we've actually got some models to say, invest now and you will make huge money into the future at a global level, and we'll begin to have this available for different countries, this model for different countries to use to put in their data, to actually be looking at it at individual country levels as we go. And when we looked across the regions, this is applied to all the different regions. So I think it's really important to understand that investing in viral hepatitis elimination saves money. So how do we do this? And we've got to really say, how do we actually get this investment case and get people thinking about it? We need to embed it in the health agenda for the Sustainable Development Goals. It needs to be part of universal health coverage. And this is, in a way, one of the things that maybe hasn't happened with some of the country packages with UHC, and we need to make sure that that happens within countries, that they're actually recognising this as a benefit to them. We need to build political commitment and support for it. We need to use country-specific investment cases. We need to increase access to low-cost diagnosis and treatment, strengthen health systems, and integrate activities. So there is we need to be arguing strongly about this. As well, we need a multi-pronged approach, and many people will have heard me speak about this before, that it's not just one thing. So we need an investment case, and then to say it needs a variety of approaches. We need to raise awareness. As I said, many people are not aware that there is a cure for hepatitis C, that there is really good treatment for hepatitis B, and that there's a vaccine that can stop you from getting infected. We need to have engaged communities. We need prevention, be it harm reduction in some countries or health system strengthening to stop ongoing transmission in what I call the unofficial health system and the official health system in a number of countries, particularly in resource-limited countries. We need to increase testing, and we need innovative approaches. All of our models are suggesting, for hepatitis C at least, that we will not be successful in our elimination efforts because, yes, we will have treatment, and treatment has become much cheaper for most countries, but actually we're not engaging with the people needing testing. And this is why Egypt has, in recognising this, has done this enormous investment in the testing program. And this will be needed in many countries. In Australia, our own models are suggesting to us that, yes, treatment is available through our universal health coverage, but unless we upscale testing tremendously over the next year to the next 5 years, we will fail in our elimination targets. Essentially, for Hep B and Hep C, no one best model fits. But what we know, and we've learnt from HIV, and we're getting increasing evidence with hepatitis C, and I think we've still got a lot of work to do in terms of how to engage communities with hepatitis B, is that if you get tested and treated in the one place and don't have to keep on moving from place to place to place, your likelihood of being lost from the cascade of care goes down. So essentially, if you can, where that person presents, they get their test, they get their workup, they get their treatment, we know that we get much, much less loss. And that's certainly the case with HIV and data that we're showing and many people are showing for hepatitis C. and it needs to be in the primary healthcare setting. People don't like to go to the big hospitals if they don't need to go to the big hospitals, and it costs them a lot of money. They can't afford it. So and for Hep C in particular, it's simple. For Hep B, it's much simpler than we make out it to be, and we need to be getting things simple. We have a great hepatitis B vaccine, but we need birth dose rolled out everywhere. It's really, really important, particularly in Africa. And Hep C, we do need one. I hear that, and I know that people think we've got tremendous treatment, we do not need a hepatitis C vaccine. But modelling that we've recently undertaken, which is not yet published, but is about to be submitted, shows that a number of countries will fail to hit their elimination targets or have great difficulty hitting their elimination targets without some level of effective vaccine because of the nature of their health system and if they don't have quality harm reduction or systems in place. And that a vaccine doesn't need to be a perfect vaccine, but even an ineffective vaccine, well, I shouldn't say an ineffective, a vaccine of 50 to 70% effectiveness can have an enormous impact. So we don't need perfection here. We need a decent vaccine combined with treatment and quality prevention and health systems. We need to involve everybody, and I think most importantly for these two diseases, we need to get the affected communities engaged. HIV has done this very well, and we've not done it as well globally for viral hepatitis. And I would say we need to be really thinking about ways to do this, ways that we can support communities to actually help us. So that to me, if that means funding from government, if it means funding from ourselves as researchers, funding from wherever we need to actually build civil society's strength to agitate well on their behalf. Because the person that politicians listen to most is community. They will listen to community calling out their needs for help. And so I would say we've got to really think about how to get civil society more involved globally to agitate for their health rights. Again, I'd like to acknowledge all of the people that helped with this work. The WISH team, there were many people who really contributed to that modelling. Thank you.